I'm Dr. Nancy Nkansah. I'm a faculty member with UCSF School of Pharmacy. I went to pharmacy school down Florida A&M University, completed my residency training at Johns Hopkins University up in Baltimore, Maryland, and then moved up here to San Francisco a couple of years ago to join the faculty. I am based down in Fresno. I work with Sequoia Community Health Centers in the Fresno area. And just to give you a little bit of background on my patient population, I work with a primarily underserved patient population. 50% of my patients qualify for Medi-Cal, another 30% qualify for no insurance whatsoever, and only 5% of my patients have insurance. So this is definitely a topic that is near and dear to my heart, as well as medication therapy in the underserved. So if I sound like I'm really focusing on the uninsured patient population, that's why. It's because most of my patients have no insurance whatsoever. What I've done is I've broken the talk down into three main topics. The first is going to be the epidemiologic background of type 2 diabetes. Second, we'll discuss some of the medication management. And I'll provide you a little bit of the lifestyle changes that we discuss with our patients. We'll discuss some of the medicines, but I won't go into too much detail. And after that, we'll discuss some of the strategies we use with regards to controlling patients' diabetic therapy. And then lastly, we'll discuss a few of the challenges and opportunities we have to improve our care for our patients with diabetes. Before we get started, I just wanted to get a sense for who here has had personal experience with diabetes, who has had a family member with diabetes, or has even worked with diabetes. So one person. Okay, so I'd say about 80% of the room. Feel free to ask me questions. I'm used to interactive presentations since I do a lot of patient education with patients. What I'll do after each part is to stop and give you a chance to ask me any questions you might have before we move forward. What I have here first, just to conceptualize the idea for you, is a patient case. And this is typically how my patients will present to me when they come in for medication management. You have a 58-year-old female school teacher. She has a medical history of type 2 diabetes, has had diabetes for 18 years. We might have patients referred to us who are new diagnosed diabetes patients. Some have been diabetic for years, and it really depends on the reason why the primary care provider chooses to refer the patient. This patient is obese, has high blood pressure and high cholesterol. The patient's labs show an A1C of 9%. How many people in the audience know what an A1C is? A few. The A1C is the value we look at to see how well a patient's glucose level, which I'll interchangeably say glucose or sugar, but to let us know how well their glucose levels are controlled over a 3-month period of time. So this lets us know when patients come in and they tell us, oh yes, I've been checking my sugar levels, we know really whether they've been controlled or not. And it allows us to make decisions as to what to do with the patient's medications and whether to adjust them or not, and how high we plan on adjusting those medications. The patient's LDL is 120, and we'll go into this a little bit later, but we like our diabetic patients to have LDL levels less than 100. The patient's blood pressure is 150/90, which in our diabetes patients, we like less than 130/80, and fasting plasma glucose level is 170. And we usually like that number to be between 80 and 120 or 90 to 130. It really depends on the clinician you're working with. This patient is on multiple medications, which is typically the case for our patients. She's taken metformin, 500 milligrams 2 times a day. She's on glipizide, 5 milligrams 2 times a day. She's on insulin, which a brand name insulin is called Lantus. She's on a medication for her blood pressure, a medication for her cholesterol, and multivitamins, which you'll notice a lot of patients as they begin to get older take multivitamins as well as calcium. So you'll see for this woman who's a school teacher, she has to teach little kids. She's taken, 4 medications a day, and I count supplements when we discuss medications. A lot of patients don't realize that supplements to some extent are medications because they do impact your body. So let's discuss the characteristics of diabetes. From an epidemiologic standpoint, there are a lot of patients that have type 2 diabetes, and the number is increasing. 21 million people in the U.S. have diabetes. That's about 7% of the population. And as you can see, the number was previously 18.2 million. So this is increasing gradually as the rate of chronic disease increases as well. What is more concerning is that about 1/3 of these patients don't know they have it. And this is where we need to do a better job from a primary care standpoint in screening our patients and ensuring that we're picking them up and starting therapy as soon as possible. It's the 5th deadliest disease and the 6th leading cause of death listed on death certificates. So a highly morbid and difficult disease to treat. It's estimated to be quite expensive, about $132 billion in 2002. 1 out of every 10 healthcare dollars are spent on diabetes. So if you can think of all the different disease states we treat, 1 in every 10 of those dollars, about 10% of our funding is going directly to this one disease state. And about $92 billion in direct healthcare costs and $40 billion in indirect healthcare costs. You can see here how over the past 10 years, and even we're in 2008 now, so I need to update my slides, but how the incidence of diabetes is increasing with time. And you'll notice that in certain states, the black belt down in Alabama, Mississippi, Florida, even California is pretty high on that list. The rate of diabetes is quite high. And to some extent, that's slightly influenced by the number of minorities, Hispanics, African Americans in those particular communities, just because those patients tend to have a higher risk of developing diabetes. But you can see that there are definitely certain states that have a higher incidence compared to the others. If you look at the numbers, you'll notice that most patients tend to develop diabetes as they get older. About 10% of patients in the age group 40 to 60 years of age will have diabetes, and you'll see the number increase as patients get older. From a risk standpoint, the patient populations that tend to be at the highest risk of developing diabetes are Native Americans, African Americans, Latinos, Pacific Islanders. But regardless, you can see the rate is quite high, and in all groups, the rate is steadily increasing. So, what is diabetes? A lot of times it's very difficult to understand, for people to understand what is diabetes and what causes diabetes. But essentially, it's a metabolic disorder that results in a relative lack of insulin. And it really depends on how the patient presents. Typically, let's see, and I'm trying to bring it down to layman's terms, but typically, when a patient presents, they have half of the function in their pancreas to secrete insulin. And insulin is that hormone we need to help us utilize glucose in our systems. So when a patient is finally diagnosed with diabetes, they've already lost half of their function. And that's why a lot of times we begin to start medications as soon as these patients present. It's characterized by 2 different factors we look at: impaired insulin secretion and insulin resistance. What you'll notice is a lot of people nowadays, due to the higher calorie diets we have and the increased portions of foods that we eat, a lot of people are beginning to have a higher risk factor for developing diabetes, and they begin to develop insulin resistance. And I'll show an illustrative schematic to show you exactly what happens. But what essentially happens is, as you begin to develop insulin resistance, your body begins to lose its ability to secrete insulin. And that's what begins to start the pathogenesis of developing diabetes. And that's what we seek to modulate with the medications we use. You'll also know that there will be alterations in lipid and protein metabolism as well. About 90 to 95% of patients who have diabetes have type 2 diabetes. So that's the predominant type of diabetes most people present with. And there are various different risk factors. As you saw in the slides I presented earlier, as we get older, our risk for diabetes increases. As our weight increases and as we lead more sedentary lifestyles, that increases as well. And the obesity and physical inactivity factor is the main reason why this incidence is increasing over the past decade. Patients who tend to have heart disease, prediabetes, signs of insulin resistance, such as the medical term is called acanthosis nigricans, but basically it's a demarcation to some extent in their skin where you'll notice a thickening in the skin between their fingers and around the neck area. You might notice it in some people's. It's a telltale sign that the patient is beginning to develop insulin resistance. People who have a family history of type 2 diabetes, and that's the main question we ask a lot of people, especially when they're younger, so that in these kids, because now childhood diabetes is a more prevalent issue, that's one of the things we target for our kids. and people who have a history of diabetes while they're pregnant, high blood pressure, and high cholesterol. This shows you that really when it comes to type 2 diabetes, especially given the fact that a lot of people now who has diabetes are obese and they're overweight, insulin resistance is the main factor that we tend to target from a treatment standpoint. And you'll notice that a lot of these patients have comorbid disease states. They have cardiovascular disease, hypertension, hyperlipidemia, and we'll discuss this a little bit more, IFG and IGT over on your right-hand side. That is indicative of prediabetes, and those individuals are at increased risk of eventually developing diabetes. So these individuals tend to have what we call a constellation of other types of disease states. And if you add a genetic predisposition, which could be just due to our individual genetics or due to the fact that certain types of patient populations at baseline have a predisposition to developing diabetes, and add environmental factors such as sedentary lifestyle and our increased portion sizes, you can see how all of this comes and plays a part in us developing diabetes. My students tend to like this schematic because it's real life, and this is what happens. Years and years ago, we didn't have these foods that we have now, these good, highly caloric, highly dense in fat and cholesterol foods. And I put fast food up there, but that's not entirely accurate. Most of the restaurants we go to and you might have noticed over the years, our portion sizes are increasing. So when we eat these large diets, we eventually begin to develop what is called abdominal obesity. And that's one of the significant risk factors we look at, and we see in a lot of our patients who have diabetes. And the abdominal obesity is particularly in this region. And this increases your likelihood of developing diabetes from a pathophysiologic standpoint. These patients have a higher BMI, which is a body mass index, and that's indicative to us of you having a higher risk for developing certain types of cardiovascular disease and other metabolic disorders. These patients also have hypertension, hyperlipidemia, and obviously a high waist circumference. What begins to develop, as I showed you in the previous slide, is insulin resistance, meaning their body isn't utilizing insulin as well. Their body isn't using insulin as well, and that's why they begin to progress on to develop type 2 diabetes. And what happens with insulin resistance is that you have a high level of insulin in your blood, and that begins to destroy your beta cells. And your beta cells are what secrete insulin for your body to utilize so that you uptake the glucose and your system works appropriately. Once you have that impaired beta cell function, as I mentioned before, a lot of our patients come with only half of the function of their beta cells. They're pretty much type 2 diabetic. And that's how that works essentially. The most important part in identifying our patients with diabetes is to screen. And you'll notice a lot of times when you go in to see your primary care providers, you'll notice that a fasting plasma glucose is one of the items that they order. And they look at to see whether you're pre-diabetic or whether you appear to be developing diabetes. We recommend for all patients who are overweight and with significant risk factors to be screened for diabetes. And you can be rest assured, for the most part, your providers are screening this. This is a common area we screen. In my patient population, I tend to have issues because a lot of my patients are unable to access the healthcare system and do not show up until they've had diabetes for quite a while. We also screen patients who are over the age of 45 years. And ideally, as I mentioned before, your provider will look at this on a yearly basis, but based on the guidelines, they're only really required to do this every 3 years. So this is something you can ask about when you go in to see your physician, nurse practitioner, or PA. In terms of diagnosing a patient with diabetes, there are 3 different tests that we can possibly use. And the most common test is the middle one there, the fasting plasma glucose. And what your provider will ask you to do is to not eat for about 8 hours, basically not eat the night before you go into the lab. And they'll check your blood, and if your fasting plasma glucose level is equal to or greater than 126, they'll ask you to go back. You go back again, and if the level is still above that, they'll go ahead and diagnose you with diabetes. And we'll discuss then what happens in terms of treatment. The other 2 tests are not as common, but the first one is really more so a diagnosis based on symptoms. You have a patient that presents to your clinic. The patient tells you they're very hungry, they have to urinate a lot more than usual, they're very thirsty. You might just check with the glucometer or ask them to go into the lab and check to see what their glucose level is. And if that's greater than or equal to 200, we'll quasi almost say you have diabetes, but we'll have you go in one more time just to make sure that's not a misdiagnosis. And the last test, which is actually pretty sensitive, however, it's not really used as often because it's pretty inconvenient for the patient. But what they have you do is they have you ingest a load of glucose. And after that, they check your postprandial glucose level, which means your glucose level after you ingest a certain amount of glucose or carbohydrates in your system. And 2 hours later, they check that level. And if that's greater than or equal to 200, then they'll diagnose you with diabetes. And again, they'll repeat the test to ensure that you actually have diabetes. Pre-diabetes is yes, ma'am. Oral glucose tolerance test. And that's the load your provider would ask you to ingest, and then 2 hours later, they check to see what your glucose level is. Prediabetes is a relatively new concept. It's kind of interesting because you'll notice as more and more studies are published, the guidelines become more and more stringent with regards to regulating patients and ensuring that they're within a particular range. A few years ago, they came up with the concept of prediabetes, which is essentially a patient that is still technically normal, technically not diabetic. However, based on their glucose levels, they're close to the point where they'll eventually, possibly, develop diabetes. And I say possibly because not all patients develop diabetes who have pre-diabetes. They have two different ways in which you can be considered to be pre-diabetic. The first is called impaired fasting glucose. And that's essentially when they check your glucose level in the morning, what that level is. And if it's between 100 and 126, so again, you could have a level at around 100 and technically that's still normal. But because you're closer to the higher side, they say that you have prediabetes and you're at risk for developing the disease state. Impaired glucose tolerance is the level you have after you eat. And if that's between 140 and 200, after a 2 hour, they put oral glucose tolerance test, but for some people, it's really after they ingest a large amount of carbohydrates. They'll go ahead and diagnose you with prediabetes based on the impaired glucose tolerance. About 26% of the population greater than 20 years of age had impaired fasting glucose. And again, a big public health issue because as the number of people who get prediabetes, or I shouldn't say get, but who are categorized as pre-diabetic increases, then we increases potentially the prevalence of diabetes in our population. As I said before, not all people with prediabetes will eventually develop diabetes, and that's an important note. And lifestyle changes are important. Once we screen these patients, our first measure in targeting their therapy is to focus on lifestyle. There was a study published a few years ago that is called the Diabetes Prevention Program, and this study was conducted to see whether we could prevent or delay the development of type 2 diabetes in people with impaired glucose tolerance. In this study, they randomized about 1,000 patients to receive intensive lifestyle modifications, which included weight loss as well as caloric restrictions, to start on metformin, which is currently the first recommended medication for diabetes, or placebo, which is no therapy whatsoever. And we showed that those patients who are on metformin therapy, their risk for developing diabetes reduced by 31%. But what's even more important is those patients who actually implemented lifestyle changes, their risk lowered by 58%. So you can see that a lot of patients who eventually develop diabetes, they're developing diabetes because their lifestyle is putting them at significant risk. And it's really taxing their pancreas and their body so that they are no longer able to compensate. This slide shows you in the placebo population what the incidence of diabetes was. And the absolute number is relatively low, but if you think about it, this could be extrapolated to mean 11% of the US population. But after lifestyle changes, that was lowered by about half. And if you look at the number needed to treat, which is basically a number that we look at to see how many people would need to implement the particular intervention you see in the columns to demonstrate the displayed benefit, you see that only 7 people need to implement lifestyle changes for us to prevent 1 case of diabetes. So that's pretty powerful there. And that's why a lot of the providers, I know patients hate to hear this whole lifestyle, exercise, diet thing, but it really does help. And I always tell my patients that's the first thing they can do for me to help me manage their medication therapy. The reason why we are so concerned about diabetes from a morbidity standpoint is the fact that diabetes is associated with a lot of different complications. The complications are broken down into two main types. You have your macrovascular complications and you have your microvascular complications. And macro, if you just kind of think of the prefix, that means your large vessels. So you could see that that's heart disease, peripheral vascular disease, which would be your legs and your limbs, or stroke, so the vessels going to your brain. And patients who are diabetic tend to have a 2 to 4 times higher rate of dying from heart disease. This is the leading cause of diabetes-related deaths. So when you see a lot of patients who are having heart attacks, patients who have angina, a lot of these patients have diabetes, and they're at higher risk for developing this. So you can imagine not only are they on their 7 diabetes medications, as we saw in the beginning, but then they begin to be placed on other medications for heart disease. So the medication list will significantly rise. A lot of patients come in complaining of peripheral vascular disease, which means that they don't really feel a good sensation in their legs, and their circulation is not as good as it should be. And that begins to play a part in some of the other slides I'll show in just a minute. Stroke. About 73% of our diabetic patients have high blood pressure, which increases the likelihood of developing stroke. Another concern. And this, the risk for stroke is similar to that for heart disease, 2 to 4 times higher risk. The other type of complications that we see in diabetic patients are microvascular complications. And this will include nerves, your kidneys, your eyes, your, I'm missing one, your gums. So a host of different complications. But one of the main complaints we get for our diabetic patients, and unfortunately, sometimes a reason that we diagnose some patients is they come in with nerve damage. They come in complaining of a tingling sensation in their limbs and their legs, kind of like a phantom pain that some people have once they've had an amputation. And about 60 to 70% of our diabetic patients, unfortunately, begin to develop nerve damage. This results in impaired sensation, as I mentioned before. A lot of other patients, here where you see slow digestion of food in the stomach, begin to develop a condition which is called gastroparesis, where they're unable to digest their food very well. So the gamut, and it just spirals downward with that. Our patients have kidney disease, especially if they're not treated appropriately over a long period of time. You'll see that type 2 diabetes is the leading cause of end-stage renal disease. It accounts for about 44% of new cases. Yes, ma'am. It's an issue really just with the nerves, where when your nerves aren't working appropriately, then it increases the likelihood of you developing that type of pain, especially when you're doing those types of jobs where you're pumping the blood pressure pumps or you're working at a computer. So a lot of this is the risk issue. Eye disease. Diabetes is the leading cause of new cases of blindness in adults within that age range. And what you might have noticed when you go to the dentist is a lot of recommendations when it comes to periodontal disease, and the fact that patients with diabetes are at a higher risk for developing periodontal disease. And the reason for all of this, if you can imagine your blood vessels, you can imagine your blood vessels essentially being loaded with sugar in the system. And you can see how having such a high level of sugar and a high level of insulin begins to destroy a lot of these vessels and basically compromise the integrity of them and their ability to work appropriately. This slide right here illustrates a typical ulcer you might see in a patient with diabetes. And this is due to some of the peripheral vascular disease they have, where they're not having really good circulation in their legs. So they're unable to feel when they have wounds like this. But not only that, as I just mentioned, remember a lot of these patients have a lot of glucose in their system. So when they do have a wound, you can imagine bacteria loves to suck and feed on sugar. So the bacteria just builds up there. They're unable to feel it. They're unable to really even notice that's there. And that's why we really focus on foot care in these patients. Really bad ulcers that are untreated and bacterial infections can eventually progress to diabetic gangrene. And this is what leads to a lot of amputations. And you'll see in this patient right here, this patient has essentially had all of their toes amputated. And that's what happens. Gradually, one toe goes, two toes go. And sooner or later, then you have a foot have to be amputated. And that's due to the poor circulation. And this is quite typical in our or poorly treated diabetic patients. Does anyone have any questions as of now? It's multifactorial. It could be both of those. It could also just be due to your age. A lot of times our organs don't work as well as they did before. So a lot of those different factors contribute to eventually developing it. I have some patients 70 years of age, no risk factors whatsoever, who develop diabetes. And that's just due to their bodies essentially beginning to shut down. They could have, and it's quite possible that they might have developed diabetes at 50. But because of their lifestyle and the way they ate, they staved it off for that long. A lot of these chronic disease states that we're beginning to see now are because our lifespans are increasing. So back years ago, as you know, we didn't live this long. So now that we have people living to 80 and 90 years of age, our bodies can only function but so long, and that's what begins to happen. So some of our patients who present who are slightly disappointed that they develop diabetes, I do tell them, well, maybe you could have developed it earlier. You know, like maybe we're lucky here. And from a management standpoint, remember, as I mentioned before, we manage cholesterol, we manage blood pressure. A lot of those things we manage to prevent a lot of the end stage complications. So the good thing with diabetes or with developing it later is you're so old, you're really not going to develop those complications anyways. So that's why you'll see when it comes to treatment goals, a lot of the older patients, the goals are a little less stringent than our patients who are diagnosed at 40. So for example, you could have a patient who's had diabetes for, I have a patient who's had diabetes 5 years, but her A1C has consistently stayed at 15%. We can't get her sugars under control, and she's beginning to develop signs like this. So this is really reflective of poor glucose management. This is not necessarily reflective of how long you've had the disease. Any other questions? Usually for these patients, it depends on the patient. You might have a type 1 diabetic who, and this right here isn't one of my patients. I got this for one of the physicians I work with. But usually what happens is a patient might have type 1 diabetes, right? And what causes these types of lesions is the hyperglycemia. It's the high glucose levels in your system. So you could have had diabetes at a young age, let's say age 15, and after 25 years of age, you are so, how should I put this? You have so many complications because you've had high glucose levels for such a long period of time that your body no longer is able to function the way it should. And that could increase your likelihood of developing this because then you begin to have some of the peripheral vascular disease and some of the nerve damage, which does not allow you to feel a lot of these things. So this isn't something that you just see in patients who have had diabetes for a long period of time. This is something that you can see in any patient with diabetes that is poorly managed, that has poor vascular circulation. It depends. Really, in primary care, they have, and I wouldn't even call it a measurement of vascular circulation, but they have the ankle brachial index that some providers might test, but really we go based on symptoms. You have a patient comes in, they tell you their feet are always cold, or they don't feel the blood in their feet the way they used to, and then you really just ascertain that they probably have some form of peripheral vascular disease. But there's not much we can do once you get to that point. Usually I tell my patients once they begin to develop a lot of those complications is that we need to just stave off the development of further complications. That's what we try to avoid by a lot of the therapy. Alrighty. So as we mentioned before, diabetes was the 6th leading cause of death listed on death certificates. Diabetes is likely to be underreported as a cause of death because if you think about it, there are many different complications that are associated with diabetes. A patient could have a heart attack and die, and they put heart attack on their death certificate when it was really due to their significantly higher risk of developing a heart attack due to their diabetes. And as we mentioned before, overall the risk of death is significantly higher in patients with diabetes compared to those without. Complications in pregnancy. We like to make sure our patients who are pregnant have adequate glycemic control as well. Patients who are poorly controlled have an increased risk of developing birth defects And patients who are poorly controlled during their second and third trimesters have a higher likelihood of giving birth to larger babies, and that's the big baby syndrome we see. So you'll notice that a lot of patients with diabetes who are pregnant will be on insulin therapy to ensure that they're controlled appropriately. A lot of the patients who are referred to the hospital or who are sent to the hospital in some sort of ketotic crisis or in a coma or whatnot have metabolic conditions that are related to significant hyperglycemia that has been left untreated for a long period of time. And people with diabetes are more susceptible to a lot of other illnesses. So the reason why I present to you all of this information is so that you understand why when we treat diabetes, we target diabetes from several different approaches. It's not just about lowering the glycemic levels. It's about lowering the glycemic levels, it's about lowering the cholesterol, the blood pressure, it's everything to lower the end aggregate risk, essentially, of developing a lot of these complications. So in summary, improved cholesterol can reduce heart complications by about 20 to 50%. That's why we target cholesterol. We request our patients to go in for eye examinations on an annual basis, and that has been shown to reduce their risk of eventually developing blindness. We ask our patients, a lot of you ask questions about the ulcers and the amputations. One of the key educational points we make for the patients is for them to ensure that they go in and receive foot exams from podiatrists. We also emphasize the importance of checking their feet every day. So a lot of this sounds pretty simple, but you can see obviously that it's neglected by a lot of patients because they don't know any better. Kidney disease, we seek to lower their blood pressure as well as using certain types of medication therapy which can lower their risk of progressing to kidney disease. And that's the ACE inhibitors and the angiotensin receptor blockers you have right there. So diabetes complications carry high morbidity and high mortality, but most of them are pretty preventable, or at least you can stave them off with good glycemic control. There was a large landmark trial conducted over in Europe, and the trial, the acronym is UKPDS, United Kingdom Prospective Diabetes Study, and that study showed that a reduction of A1C by close to 1% can reduce risk of microvascular complications by about a quarter. And if you remember, the microvascular complications are the kidney disease, the eye disease, the periodontal disease that you notice. And by reducing the patient's systolic blood pressure, that's that top number of the blood pressure, you can significantly reduce their risk of stroke by 44%, and their overall risk of microvascular complications by about a third. Any general questions about the epidemiology before we move on to medication management? Because if you think about how diabetes work, it's a genetic predisposition. So if the mother has diabetes, the child already has that genetic predisposition, and depending on their lifestyle, they'll develop it. So from a pathophysiologic standpoint, no. Now, what they might have meant is if the mother who has diabetes after the child is born controls her diabetes appropriately, then from an indirect standpoint, then usually children tend to exhibit the lifestyles of their parents, and then that might lower the child's risk of eventually developing it. And from when we target childhood diabetes, that's one of the avenues we take to target preventing these children from eventually developing diabetes. We focus on the families and the lifestyles. Any other questions? Yes, sir. Okay, type 1 diabetes is an absolute lack of insulin. These are patients who at some point in their life, usually they have some sort of autoimmune disease that destroys all of the beta cells in their pancreas, which produces insulin. So those patients have no insulin whatsoever. And those patients usually, they're only treated with insulin therapy. Actually, insulin is the best medication we have out there to lower glucose levels. The problem is that most patients don't want to take it. And it has, and I won't necessarily say that, I will say that. Most patients do not like to take it because it's injectable, but there are also caveats with that therapy as well. It makes you gain weight. If they take too much insulin, they develop hypoglycemia. So there are issues with insulin therapy, but it's our most potent medication. And that's actually a strategy a lot of providers are using. A lot of endocrinologists are starting patients on insulin therapy a lot earlier. Some patients even when they're diagnosed. All right, so let's go into the medication management. How many of you have seen a glucometer before? It's okay. So it's the machine that can check to see what your glucose levels are, right? And usually our patients will only check their glucose levels maybe once, at the most 4 times a day. Now what this slide shows you is what happens to anyone's glucose level during the day. And you can see that they're really all over the place. It depends on what you eat. But what's important with diabetes is the fact that a lot of these patients are unable to bring their glucose levels back down to that normal range we want them to be, that 70 to 100. So that's the largest concern we have in our patients. And this shows us, the other point here is that by checking your glucose levels just once a day, that is not reflective of how well your glucose is controlled over the period of 24 hours. So a lot of times as practitioners, we don't really have the entire picture of how well your glucose levels are doing. We have a lot of patients who come in, their glucose levels are 110, we think they're doing fine. We get an A1C level that is 9% and we know something is wrong. So you know that there's some level sometime during the day that's out of control that we're not getting. From a glycemic goal standpoint, and you asked this earlier, we look at both our preprandial levels and we look at our postprandial levels. So preprandial glucose levels, we like those to be in a diabetic patient. These numbers are not indicative of normal patients. But in a diabetic patient, we like them to be between 90 and 130. All right? Our bedtime glucose levels, we don't look at as often, but we also look at the postprandial levels. And we like those levels to be less than 180. The 180 is the guideline based on American Diabetes Association. However, AACE, the endocrinologist organization, actually would prefer for the postprandial levels to be less than 140. So usually in my patients, I target postprandial levels less than 160. The A1C level, we like for those to be less than 7%. So let me put this in context. You have a patient who comes in with type 2 diabetes. The patient comes in with their glucometer readings, which we call self-monitored blood glucose readings. And if those readings, when I average them out, are greater than 130, let's say they're 150, then I would adjust the patient's medication. If the patient is checking postprandial levels, which are levels they check 2 hours after they eat, if those levels tend to be over 160, then I'll adjust their glucose, their medications accordingly. And the medication I choose to adjust is going to depend on which of those values are high and which medication they have on board. So that's when it becomes somewhat complicated. The other measure I look at, and I briefly mentioned this before, is the A1C. The A1C is the most important number we like our patients to be familiar with when we manage their diabetes. That lets us know how well they're controlled, again, over a 3-month period of time. So when I have these glucose readings, and I'm showing them to be in control based on their glucometer testing, but I'm showing their A1C levels to be higher, then you know that there's something you're missing in that picture, and that something needs to be adjusted from a medication standpoint. All right. Aside from the glucose levels that we target, we also target various different metabolic parameters. We target the blood pressure, I mentioned before. We want that to be less than 130/80. We target the patient's cholesterol, ideally less than 100. However, a report was released a few years ago that actually recommended LDL levels less than 70 in select patients. And these are patients with cardiovascular disease and other risk factors, patients who have previously had a heart attack or some form of angina. We recommend for HDL levels to be greater than 40 in men, greater than 50 in women, and we like those triglyceride levels to be less than 150. So what essentially happens is we have patients on maybe 3 or 4 medicines for their A1C. They're on, if they're lucky, just 1 medication for their blood pressure, but usually 2 or 3 medications for that. They're on a medication for their cholesterol, and they might be put on another medication there for their triglycerides. So that's where you begin to see a lot of these challenges in getting patients under control. When anyone is taking, I'd even say more than 5 pills a day, it becomes very difficult. The ADA guidelines in 2008 recommends for us to check our blood pressure at every clinic, and this is typically done when your vitals are assessed. We recommend, as I mentioned before, annual foot exams, annual retinal exams, annual lipid checks. The microalbumin is a parameter we look at to see how well your kidneys are functioning. And that's something that we look at. We ensure that you have all of your immunizations because patients with diabetes tend to be at a higher likelihood of dying from infections related to these particular infections. And we focus on coronary heart disease prevention, meaning a lot of the patients are on aspirin therapy or on ACE inhibitor, which is a blood pressure medication therapy, and smoking cessation because diabetes patients who are smoking are at high risk for heart disease. Another tool we use is this tool right here, which allows us to relate our A1C levels with the patient's likely average glucose reading, and it helps with management as well. So if you have a patient with an A1C between 8 and 9, you can see for the most part their plasma glucose levels are in the 200s. And that's something as clinicians that we take into mind or take into account when we decide how to manage or adjust a patient's medication therapy. Recommendations were recently published back in 2006, so about a year and a half ago, which basically the purpose of these recommendations were to help clinicians best treat and manage diabetes. The difficulty was that there were so many different paradigms that try to summarize or guide people on how to manage diabetes, and it became very confusing. And they really sought to condense all of the knowledge and help to provide us with some sort of guidance on the best way to ensure that patients reach their goals. First, we want to initiate or change therapy if the patient's A1C is greater than 7%. And if you remember, the goal is less than 7%. And you want to maintain that A1C at less than 7%. And you'll see some studies and some practitioners that will actually try to manage patients and keep their glucose or their A1C values as normal as possible. So some people will actually target 5 to 6%. I'm somewhat personally skeptical of that just because a lot of patients become hypoglycemic, and that's another concern. But it really depends on the clinician and what they choose to do with regards to keeping your A1C below 7 and how low they want it to go. There are multiple different medications nowadays to treat diabetes. If you think back about 10, 15, 20 years, the only medications we had were insulin, as you mentioned, which is still our best medication, and the sulfonylureas. Now we have many other medications that can be used for diabetes. And they're all, for the most part, pretty effective in lowering A1Cs. This is, it's a dizzying algorithm that we study and we familiarize ourselves with to help guide us on which medication to choose when. And essentially, it shows us that, for the most part, we've been managing patients right. The first step in patients with diabetes is to always start lifestyle. As I said before, lifestyle is very important. And the change in the recommendations is to start metformin therapy at the get-go. Usually, what we would do before these guidelines came out was you'd have a patient referred to you for diabetes, brand new diabetic. I'd implement lifestyle changes, which means I'd ask them to lose about 5 to 10% of their weight. I'd help give them different types of steps they can use to lose that weight, and I'd ask them to begin to exercise a little bit more because that helps you lose about 1/3 of your weight as well. And then after that, we'd bring the patient back after a couple of months and see if it worked. However, what these experts found was when they looked at all of the studies and they looked at clinical practice, most of these patients, when you send them out for lifestyle therapy, come back and need medication anyways. So given the fact that you have a lot of different risk factors for developing a lot of the complications over time, we're targeting the patients earlier. So those of you who might know people with diabetes or who have diabetes yourself, you might notice that a lot of people are being started on metformin therapy. What I've already discussed the importance of glucose ranges and keeping a patient between the glucose range of 90 and 130 for their fasting plasma glucose levels, and for their postprandial levels, keeping them pretty much less than 160 2 hours after they eat. Another factor that we look at is the patient's postprandial glucose level as well. So we like the fasting and we like the postprandial, but a lot of times clinicians will just focus on the fasting plasma glucose levels. And I'd say they're missing half of the picture. It's easier to do. That was really the paradigm many years ago, but a lot of the data has shown that we need to look at both, and we need to target both. And there are medications that do target both. Granted, though, it increases the number of medications you have on board. So two concepts. One, the concept of insulin resistance. Whenever you have a patient who comes in, as a clinician, the first thing you consider is whether the patient has only insulin resistance, which means they're not utilizing their insulin appropriately, or does the patient have impaired insulin secretion, which means they're not secreting enough insulin. And that's going to impact the type of medication you use, or whether you think the patient has both. And then after that, when it comes to adjusting therapy and deciding exactly what to do with the medication therapy, then you take into account the patient's fasting plasma glucose levels and their postprandial glucose levels. So you can see all of the different thoughts that are going through your clinician's head when they try to decide what to do with medication therapy. Now let's stepwise discuss what happens initially, and then after you receive your initial patient education, how in a stepwise fashion do we seek to get glucose levels under control. From a patient education standpoint, a lot of our patients are slightly irritated or annoyed when you schedule the infamous disease state education session. And a lot of times they really don't understand how important it is for us to have that. And it's essentially, it's almost kind of like you're sitting here today. How many of you really feel like you really understand all of diabetes after the hour that you've just been sitting here? You feel entirely knowledgeable now of diabetes? But usually patients, when they're diagnosed, have 15 minutes with their physicians, only 15 minutes. And in that amount of time, we expect them to understand how the disease works, understand how it occurs, understand how they might develop all these complications, and on top of that, understand all their medications and how they work, the side effects. So that's just impossible. No one can do that. So that's why we like to schedule multiple disease state education sessions, and we schedule a lot of visits. We like to outline for our patients the treatment goals and why we seek to achieve certain goals. We discuss with them the signs and symptoms of hypo and hyperglycemia, discuss their medications, common side effects, as well as what we need to monitor from a medication side effect standpoint. This is a common illustration we use for a lot of our patients, and it allows them to visualize some of the symptoms they might realize when their glucose levels are way too high. Patients tend to be, and we call it usually the 3 Ps, polyphagia, which are the patients tend to become very hungry, they eat a lot, although they tend to lose weight. Polydipsia, they become really thirsty. Polyuria, they urinate a lot. And those a lot of times are the 3 hallmark signs you'll see in patients with undiagnosed type 2 diabetes. When the patients do come in to see you, some of them might have additional complaints as well that will let you know that their glucose levels probably are not where they need to be. And that would include the blurred vision, sexual dysfunction, as well as the numbness and tingling in the feet, which is indicative of some peripheral neuropathy, which is that nerve damage. What is even more important for us is for us to ensure that our patients know the signs and symptoms of hypoglycemia. And the reason why we need our patients to know this is if we overtreat for some reason, or if they tend to take too much of their medication, this is important for them to understand how they can best treat these low glucose levels and avoid going unconscious or going into a diabetic coma. Usually these signs and symptoms include a tremor. They might feel somewhat weak, develop a headache, somewhat irritable. Some patients sweat a lot. Some become somewhat anxious. So these are the typical signs you might see in your family members, or you might experience yourself if you're developing hypoglycemia. And we always ask our patients, how many episodes of hypoglycemia have you had in the past month or in the past few weeks prior to seeing us, so that we can best decide what to do with the medication therapy. With regards to treating hypoglycemia, essentially it's intaking glucose, 3 to 4 glucose tablets, a few pieces of hard candy, some juice. A problem that some people have is they'll become hypoglycemic and they'll drink an entire can of soda, which then overshoots them and sends them back hyperglycemic. So it's important to understand that you only need a little bit really to rebound your glucose level when you become hypoglycemic. And we recommend for all of our patients to have glucagon kits down the bottom. And you can get all of those in the pharmacy. All right. So after our patient education session, then we begin medical nutritional therapy, and really I just like to call this lifestyle changes. We focus on weight loss. We ask our patients to exercise for about 30 minutes, 3 to 5 times per day, and we focus on their portion sizes and patients ingest in a low-fat calorie diet. And there have been some studies showing that low carbohydrate diets can be effective as well. However, the concern with that is going to be protein and the amount of cholesterol they're ingesting with the so-called Atkins diet and whatnot. Obviously, before beginning any physical activity program, we ensure that the patient has at least seen a physician, and we work with the patients to help them gradually build up their exercise regimen. From a dietary standpoint, we make the typical recommendations you would see provided in the food pyramid guideline. Less than 30% of the diet should be composed of fats. Less than 7% of all calories should be based on saturated fats. We minimize trans fats, and we really focus on the nutrition facts label. It's amazing how many people do not read the nutrition facts label when they shop. Yet it's very important because it allows us to know how much we're really eating and whether when you eat that serving of, of potato chips. I have patients all the time who come in and say they had 1 serving of potato chips, but yet they ate the entire bag. So they don't understand. Read the back. Read how many servings are there. And this also impacts why people can't lose weight and what happens there. So a lot of education there. From a weight management standpoint, we do advise calorie restriction. We have a lot of patients, again, who come in and say, I tried to lose, 10, 20 pounds and I couldn't do it. But that's because they starved themselves. You can't starve yourself. You have to gradually cut back or your body goes into starvation mode. So it's a lot of those general educational points we make. And then exercise. And from looking at portion control, and there's a lot of slides on the NIH website, which I love, but they show you how over the past 10 years, for example, the size of the bagel, now we go to Posh Bagel and a lot of these places where the bagel size is double or triple the size it used to be. But essentially, the size we're initially eating is really what we need and the amount we should have. So a lot of that is playing in part into the overweight, the obesity, that is making it harder to control diabetes. A simple tip we provide for patients is for them to imagine their plate, about half of the plate should be veggies, half of the plate, and they gasp when we say that, but that's very important. Only a quarter of the plate should be carbohydrates, and the other quarter should be proteins. And that's one of the easier ways, especially for my patient population. We seek to help them control their diabetes from a dietary standpoint. Just because when you go to a dietitian, they give you this long list of everything you shouldn't do, and it becomes very difficult to manage from a lifestyle standpoint. The other key educational point we make is calories in equal calories out. If you're putting them in and they're not coming out, that's where you're gaining all of this weight. And it's a simple concept that a lot of people do not understand. And unfortunately, a lot of people also think that by exercising, you can eliminate a lot of your weight and lose a lot of weight, but that only gets rid of about 1/3 of the weight we gain. Really, it's going to be a caloric restriction that helps to lose weight. And we discussed this. Again, slow but progressive weight loss. Don't starve yourself, just gradually begin to cut down. So for my area of specialty, medications. There are many different types of medications now on the market for diabetes. We have here, they call them hypoglycemic agents because they increase your body's ability to secrete insulin. So thereby they lower your glucose levels by increasing insulin secretion. And I'll show you visuals of all of these medications. You have your body biguanides and your thiazolidinediones. And you might have heard about the TZDs, Avandia, on the market with regards to heart attack risk and fractures in certain patients, and whether or not that's actually a true risk that we need to be concerned about. Alpha glucosidase inhibitors. These are agents that basically, to some extent, impede your body's ability to absorb carbohydrates in your system. Dipeptidyl peptidase 4 inhibitors. They allow your body to utilize your glucose better, and they increase secretion of or reduced secretion of glucagon in your system. Insulin, we'll go over that briefly. Exenatide somewhat works with the sitagliptin as well from a postprandial standpoint. All right, so we already discussed this. Development of diabetes requires a defect in your beta cell function. Once patients are diagnosed, they already have lost half of their beta cell function, and they develop type 2 diabetes. And it's important to understand that to understand the different ways in which we treat patients with diabetes. On the top left-hand side, you see here are medications that affect the pancreas. Right here, you see medications that affect the liver, hepatic metabolism. We see the medications that affect the gut and those that affect the muscle. Most of our patients with diabetes, you'll see, are on oral medications. And it's due to the fact that most people prefer to take a pill as opposed to inject themselves. His question was, is there such thing as an insulin pump? The difficulty with insulin pumps are usually you don't use those in your patients unless they're very, very, very poorly controlled. Or you might use it in a type 1 patient because they're dependent on insulin. But for most of our type 2 diabetic patients, they're well controlled on oral medications, or you can use the pens to administer insulin. Insulin pumps, they're expensive, they require insurance, they require continuous monitoring because from a hypoglycemic standpoint, you have got continuous insulin. But some patients do elect to have it and some patients do pay for it. The other issue with insulin, and we'll discuss this on another slide, is insulin can cause you to gain weight, and people do have problems with that as well. This slide right here illustrates our sulfonylureas. This is one of the most commonly used medications for diabetes. Just to give you a few points about sulfonylureas, I previously mentioned they increase secretion of insulin. They work pretty well, actually. The problem, though, with sulfonylureas is that usually after about 10 or so years that the patient has been on therapy for a while, they lose response to it and they don't respond as well. So you eventually have to transition patients off of sulfonylureas. And the theory with that is, since they do increase secretion of insulin from the beta cells, if you remember, as you get older, you also lose beta cell function. So eventually, you lose the ability to produce insulin. So hence, the medication couldn't work because you can no longer produce insulin. A concern with sulfonylureas are hypoglycemia because they are increasing insulin secretion. You can become hypoglycemic, and we oftentimes do have patients who come in after taking their glipizide or the glimepiride with hypoglycemia or symptoms of hypoglycemia because they didn't eat when they took these medications. Another concern is that sulfonylureas causes patients to gain a little bit of weight as well. So that's another thing you might see with these medications. And then you'll notice providers will choose a different medication dependent on whether you have kidney disease or not. And that's from a metabolic standpoint and how the medications are distributed in your body and how they're eliminated as well. These other medications, the meglitinides, they work pretty similarly to the sulfonylureas. The difference is that these are typically used for postprandial glucose levels. And that's because they work to acutely lower your glucose levels or acutely increase insulin secretion immediately after a meal. So the main education point with these medications are you must eat before you take them. Insulin sensitizers. These are the other two common classes of medications. Metformin is pretty much like our aspirin now. Everyone is on it. I'd venture to say it's pretty benign. Some patients do develop complications on metformin, and those are patients who have hepatic issues or they have hypoperfusion, which could cause a rare form, and this happens in like 0.3 cases. But they develop a condition called lactic acidosis, and that has to do with their ability to metabolize lactic acid. Very, very, very low incidence. Quite honestly, I've only seen it maybe once in one of my patients, but it's very rare. And your clinicians are typically on top of that in terms of when you go into the hospital, stopping that medication or stopping it if you have really bad congestive heart failure or any disease states that could impact your metabolism of lactic acid. Rosiglitazone, pioglitazone, that's your Avandio and Actos, the agents that have been in the media a lot. And these two classes tend to be the medications we put on board when we expect insulin resistance. And if you remember, most patients with diabetes, we expect to have insulin resistance. So most patients, if they're not started on a sulfonylurea, will eventually end up on sulfonylurea, metformin therapy, and possibly Avandia or Actos before we then venture out to try to start insulin. These agents, metformin's pretty cheap, it's generic now, but the problem with Avandia and Actos, especially in my patient population, is that they're very expensive and a lot of people can't afford them. These medications, the alpha-glucosidase inhibitors, are not used as often. They are taken immediately before a meal, but the problem with these medications is they cause a lot of flatulence, a lot of bloating. You can imagine if you're taking a medication that inhibits your body's ability to absorb carbohydrates, that really it's all just coming out the other way. And although it's been shown to reduce slightly the risk of developing diabetes in some patients, these agents are very rarely used actually in practice. Exenatide, this is one of our newer medications, has been on the market now for a couple of years. The drug reps like to coin this as the weight loss agent. It is currently right now in studies for weight loss. It's an injection that patients administer 2 times a day. I find it somewhat interesting because a lot of patients who are scared to take insulin, if you tell them this might help them lose weight, are very willing to take this. So it works. It works with diabetes. It does help people lose weight. But one of the side effects of this medication is nausea and vomiting. And we think that that might be part of the reason why people end up losing weight on this agent. And it's interesting because if you look at people who don't have diabetes, exenatide is a GLP analog, which is a hormone we have in our systems that is secreted from our guts right after we eat. And people who don't have diabetes have a normal response. But people with diabetes have a blunted response in that hormone. So what this does is it essentially replaces it to allow the diabetic patients to have a more normal secretion of GLP. Sitagliptin, this is the newest drug on the block, our newest oral medication, and it is a dipeptidopeptidase 4 inhibitor. And essentially what happens with, well, not with exenatide, but with the GLP hormone that your body secretes, is there's an enzyme called DPP4 that breaks down that substance. And in diabetic patients, a problem they have is, although they have a small amount of GLP in their system, their DPP4 breaks it down. And essentially, it degrades all of the hormone they have in their system. So you put this on board, and this allows them to maintain their level of GLP so that they can recognize or get the benefits of the GLP in their system. Insulin. Most people are familiar with insulin. However, most people are also very confused by insulin. There are various different products on the market. You have your rapid-acting insulins. You have your short-acting insulin, intermediate, long-acting insulin. Then we have mixes. And this is the hardest or the most difficult concept to educate a patient on. And it really has to do with the pharmacokinetics, how insulin works, how long it takes for it to start working, how long does it stay in your system, and how long does it act. And very complex issue, but all you really need to know is a lot of patients, when started on insulin therapy, will be started on one of these 2 agents here. Most patients will be started on these 2 agents, either glargine, which the brand name is Lantus, or Detamir, brand name Levemir. And the reason why they're started on one of these 2 agents first is because it allows them to exhibit 24-hour control. These medications last over a 24-hour period of time. Eventually what happens is, as patients have been, if patients have been diabetic for a long period of time, they no longer are able to produce insulin. So what we'll usually do is we'll keep their insulin sensitizers on board, which would be the metformin, which would be the Actos and the Avandia. And then we start this agent, and then after that, we have to target those postprandial glucose levels as well, right? So we're targeting the insulin resistance with the Actos or the Avandia. We're targeting the insulin resistance with the metformin as well. We're targeting the fasting plasma glucose levels with these, and those other medications work on fasting plasma as well. But then we've left out the postprandial levels. And that's why then patients will be started on Humalog or Novolog or Pedra to give an acute rise in insulin levels. And what you'll see is that these patients will take an insulin dose of their long-actin in the evening sometime in the mornings, and then they have to inject themselves with the short-actin insulin before each and every meal. And that's where it becomes very difficult for patients to stay compliant with their regimens. And not only that, but if they're hypoglycemic and have side effects of the medications, to decide which insulin do they adjust, which medication, and how much they should. A lot of patients will just stop taking their insulin. And that's definitely not what we want them to do. Or patients will take it one day and not take it another day, and come up with various different ways to self-manage. An important point that a lot of times we fail to recognize is the fact that medications come with significant adverse effects. We think when we're on medications, as long as our provider is seeing us every 3 or 4 months, that we're okay. But as we see with we saw with Heath Ledger and a lot of these different people who are having who are dying, but also having other issues with medications, that we're not monitoring medications nearly as enough as we really should. In order to monitor how well these medications are working, we do monitor various different parameters. The A1C is more from an efficacy standpoint. That's what we look at to ensure that the medication is working appropriately and that we're optimizing our patient's effect. Self-monitor blood glucose levels come into play as well with the hemoglobin A1C. We also look at the patient's metabolic panel. That would include their electrolytes. We look at their glucose levels, their serum creatinine. And this lets us know from a metabolic standpoint whether they're eliminating their medication within the time point or within the period of time that we would like them to. Let's think, a good example of that is glimepiride. That's one of the sulfonylureas we had earlier, and that medication is renally, which it means it's eliminated in the kidney. If you have a patient that has kidney disease, that might stay in their system for a long period of time, and they might become hypoglycemic. So these are a lot of the different factors we look at to decide what to do with the therapy. Transaminases, those are liver function enzymes to look to see how well your liver's working. A good example of that is if you have really high liver function enzymes, we wouldn't start you on Actos or Avandia because that increases your likelihood. I don't know if you've heard of Resulin. That was the first TZD on the market, and it was associated with significant hepatotoxicity. So if you already have really bad liver enzymes, it's just a precaution we take from a clinical standpoint. And then we look at weight as well. So that was a whirlwind there. Any questions in general or any personal questions you might have? Yes, sir. Right. And that will kind of confound the picture. We do recommend eating more frequently as long as the portions are smaller. A problem we have is that people will take that advice, but they'll eat several meals actually a day. So it's not that they're eating small meals more frequently, they're eating multiple meals frequently. So the first recommendation is to make sure the other meals or other snacks are healthy snacks, like vegetables or very low caloric types of snacks. And then with regards to checking their glucose levels, we usually recommend if we're checking a postprandial level, it to be after one of their main meals. And the other level we look at is a fasting level, so that's before they've eaten anyways. For our patients who are on insulin therapy, if they are eating multiple snacks a day, we take that into account and just adjust it appropriately through there. And usually they have Lantus, that long-acting 24-hour insulin on board, Lantus or Dedimer, and that provides some sort of baseline insulin secretion in their system to cover a few of these little blips with their snacks. We don't say you're not supposed to eat fruit. We just recognize that fruits will acutely elevate your glucose levels, but we do recommend for you to still eat fruits. You just have to have the appropriate medications on board to bring back your glucose levels after you have that acute spike. Because the fruits, you get a lot of nutrients from them. So we still recommend them. Basically, we've discussed the complications of diabetes. We've discussed the epidemiology, the incidence, the prevalence. We've discussed all of the medications. We have a huge armamentarium now of medications we can use to try to control diabetes. However, right now, our primary care system is pretty close to broken. We have a lot of problems in our primary care system. Total out-of-pocket spending on healthcare costs have increased from $13.7 billion to $230 billion in 2000. Have rose $13.7 billion to $230 billion in 2003. More and more medications are prescribed. That's multifactorial. It's due because we have more prescription medications on the market. Not only that, but providers are used to prescribing more medications. Our guidelines are requiring more stringent management of disease states as well. So all of those different issues play a role in increasing the number of medications that are prescribed, thus increasing the amount of money spent on prescription medications. Copays are rising. The copays for brand name drugs have increased to $26, and the price for generics have increased to $9. Right now, I think Walmart and Target are the only ones right now that have that $4 generic plan. So we're in a very difficult situation, not only for those of us who can somewhat afford medications, but for those who can't afford medications at all. Another issue we're having with this is the Medicare population and Medicare Part D, and the switching of plans and switching of drug formularies, and your physician prescribes Lipitor, you go to the pharmacy and your plan doesn't cover Lipitor, so you have to go back, and all of the intricate problems we have with that. So right now we have a lot of issues with our healthcare system. We have more patients that have chronic disease states. That's due to our lifestyle. That's due to the fact that we're living longer. Our physicians have less time with us. Now physicians have to see between 25 and 30 patients a day. That's at least 4 patients an hour. So you can imagine when the physician, they're in and they're out, they're in and they're out. They don't have enough time to sit down and really explain to you a lot of these issues that you're learning when you come to these sessions now. And with that, then how are you going to understand your medicines? How are you going to understand when you're at home and you have a hypoglycemic episode, what you need to do to manage that? How do you know when you're hyperglycemic, what needs to happen? And that's a significant concern, and that's why we have nurse practitioners, physician assistants, pharmacists, everyone really trying to use a team-based approach to ensure that people are meeting their goals. Patients are having difficulty accessing the healthcare system. That's because of the top issue there. More patients have chronic disease states. More people are living longer. We have the baby boomer population coming into the healthcare system. So multiple issues are making this worse. Not only that, but people, health insurance is becoming more difficult to afford. So it's difficult for people to even get into the healthcare system, and that further drives up our healthcare costs because people are seeking their primary care in emergency rooms. That's where they're going, and they're hospitalized, and that in and of itself is several $1,000s. And if someone has no insurance, then that comes out of taxpayer dollars. So all of this is interrelated. Primary care providers are trying to find creative ways to meet patient needs. Our patients have various different needs. Obviously, we all want excellent health care, despite all the problems we have in our current system. We want lower healthcare costs. We want to be on the most effective and the most safe, cost-efficient medications. We often think about whether medications work or not, and sometimes that's at the sometimes that's usually, it doesn't allow us to really think about how safe they are and really whether it increases your likelihood of developing another disease state because you have polypharmacy or so many different medications on your drug medication regimen. Patients want their drug therapy to be streamlined. They don't want to take 15 different medications. So what can we do? And the other issue we have in primary care is that it is so disjointed. You see your primary care physician, you see your cardiologist. If you have diabetes, you see your endocrinologist, you see your pain management specialist. Multiple different people managing one patient. And you can imagine how difficult it is for all of those different practitioners to communicate and ensure that we have just one medication list. Not only that, but patients go to multiple pharmacies. So a very complex situation with regards to managing medication therapy. Patients are looking for ways to promote their adherence, make it easier for them to take their medications, and they're looking for someone that they can depend on to answer their questions about their disease states, their medicines, and any supplements they might take. I have a patient who is on Coumadin therapy, a blood thinner, whose INR, which basically reflects how thin your blood is, shot up. And we find out 2 months later that she was taking fish oil. And that's what caused her level to shoot up. And no one would have even known if we hadn't have asked. And that's due in part because now there's a whole lot of other supplements, which I call medicines, that we have access to that we can take that also can affect our health care. I call this our report card. How well are we doing from an A1C standpoint? We're not doing well at all. About 2/3 of our patients have A1Cs greater than 7%. That means 2 out of every 3 patients are not controlled. We're doing horrible right now, despite all of the efforts, despite the NIH, despite all of the public health interventions that are being made to target diabetes. We're still not doing well in controlling patients with diabetes. Only 45% of patients even received formal diabetes education class. 24% had an A1C in the last year. The 24% is pretty low because if you remember, A1Cs are supposed to be monitored in uncontrolled patients, which, based on this, are 2/3 of our patients. Those are supposed to be checked 4 times a year. So for only 24% of our patients to have A1Cs only once a year, shows that we're really not doing our job from a clinical management standpoint. Another study showed that only 1/3 of our patients had their blood pressures controlled, less than 130/80. 50% of our patients had cholesterols, less than 200. And the worst, I think, the kicker, only 7.3, less than 10% of patients had all 3. And our target is all 3. So this is why you'll see a lot of different innovative strategies to help to better control our patients, like the diabetes group visits, or you'll see diabetes management teams that will include the dietitian, that will include a psychologist, that will include various different healthcare professionals to try to really get these patients to these goals. And we've shown it to be effective. But from a national standpoint, we're not there. We're actually not even close to there. I like this slide just because it really conveys how urgent the issue is. Every day we have 4,000 new cases of diabetes. We have 810 deaths due to diabetes, and that's likely underreported. It's probably underestimated there. 120 patients have kidney failure. So a definite high number of complications associated with poorly treated disease state from a national standpoint. Complications in minorities. We've shown in studies that the complications are worse actually in minorities compared to non-minority populations. The risk of lower leg amputations, retinopathy, stroke is 2 to 4 times higher than the other populations. The risk of ESRD, end-stage renal disease, is 4 to 6 times higher. And that has to do with the health disparities issue that we're trying to address on a different front. There are various different challenges to diabetes control, and I'm sure you can guess most of them. Number one is adherence to the treatment recommendations. In and of itself, it's very hard for anyone to take several medications multiple times per day. When I'm even on antibiotic therapy personally, I can barely take my medicine every day. So you can imagine if someone's on 2 or 3 or 4 medicines and they're taking them in the morning, for lunch, and in the evening, how difficult that might be. But on top of that, we have our patients who have cultural perceptions. We have patients every day who tell us they don't want to start insulin therapy because their grandmother died from insulin. Or you have people who do not believe in medicine therapy because that's the Western type of medicine. And they have other types of cultural aversions to using such medications. You have socioeconomic conditions, and this is the issue for most of my patients. People can't even come for their visits. They have poor access to care and medications. They have no insurance. So how do they get in to see you? Complex medication regimens, a large number of pills. There's only but so much your stomach can handle. And environments non-conducive to exercise and healthy diets. This is an issue for patients who tend to live in areas that might not be as safe. So it's difficult for them to go and exercise. It's difficult for them to find foods that are cheaper, but yet healthier than a lot of the fast foods that are on the market. So there are multiple different reasons why we have difficulty getting our patients to their goals from a diabetes standpoint. There are various different models from a pharmacy standpoint as a pharmacist that have been implemented in multiple states to improve diabetes goals. The most famous clinic is called the Asheville Project, and that's in Asheville, North Carolina. And essentially what happened was the city of Asheville entered in a contract with a group of pharmacists to provide pharmacy care or provide medication management for their patients with diabetes to help bring them closer to goal. The pharmacists adjusted the medication therapy, they provided patient assessments, they provided education, and it actually showed that there was a significant increase in the number of patients who had A1C levels less than 7%. Such clinics have been replicated in the VA system. I believe we have a few in the VA here in San Francisco. Actually, most VAs have pharmacy clinics for hypertension, hyperlipidemia, and diabetes as well. So the data is out there, and it's a direction that we're moving in from a control standpoint, especially when it comes to medication management. The UCSF model. Here at UCSF, we approach clinical pharmacy from a two-pronged approach. We have our inpatient pharmacists, but looking at ambulatory care, the primary care provider will usually refer a patient to come and see one of us, either for a one-time consult or for management of their disease state. For a one-time consult, usually what happens is we'll see the patient, we'll schedule about an hour visit with the patient, we'll ask the patient to bring in their labs, and we'll look at all of their medications, all of their supplements, any herbal therapies the patients might take, look to see whether there might be any drug interactions, ensure that all of the doses are optimized. A lot of times people are started on a particular dose and not increased to the most optimal dose that can help them achieve their goals. So we ensure that all of that is up to par and ideal, and then we forward a consult to the main provider. Other times we manage patients for a longer period of time and see them multiple times to ensure that they meet their goals, and then we'll discharge them back to their primary care provider. We're utilized as a resource to manage very complex patients. It's not just about the medication you have, it's not just about taking the medicine, but there are a lot of other physiologic factors that come into play when you discuss how does the medication work in your body. Does your body absorb the medication at the rate that it should? Does your body distribute the medication to the organs that it's supposed to go to? Are you metabolizing it appropriately? Are you eliminating it? There are various different factors that we take into account when we decide what to do next from a medication standpoint. We provide drug information, and I believe Dr. Solar provided information a couple of weeks ago on the Rayleigh's project, and that's UCSF's version of the Asheville project that we're implementing. In summary, patient education is important. It's important for us to address our patients' concerns. It's important for us to focus on patient education from a polypharmacy standpoint and to ensure that people understand their medicines, how they work, and how it might affect other disease states they have. Complicated treatment regimens, we have to also ensure that people know how to manage these multiple different medications as well as other treatments the provider might have them on. New devices, there are various different devices such as the exenatide you saw, which is a pen. You have insulin pens. You have at one point that inhaled insulin, which was a device that was this big that you had to maneuver. So there's a lot that we're requiring people to manipulate in order to treat their disease states. Maintaining appointments is important as well. From a treatment standpoint, we focus on their symptoms of hypoglycemia, on select and affordable medications they can afford, monitoring their medications for effectiveness and safety, and as I mentioned before, making sure people know how to use their medicines right. And this can require multiple visits, and it's very difficult from a cost-effectiveness standpoint to really balance the two. Balance how much money you spent treating the disease state, while at the same time realizing some of the benefits with regards to minimized complications, which in and of themselves are expensive as well. Yes, ma'am. I tend to get very emotional, so I have to hold back. But yes, I do, because especially with patients who are Medi-Medi, which means they're Medicare, Medi-Cal, what happens is, depending on how much insurance a patient has and whether they meet a certain limit, they'll switch them every year. They switch them if a plan's not available, and all of a sudden the patients have no medicines. Or the donut hole, you hit a certain level and you have to pay cash for all of your medications. And that is an issue for people, because you have people who don't value their health too much, then they stop taking their medicines altogether and they wait until the next year. Or you have people who pick and choose. Okay, well, give me 3 of those, or give me half a month of those. I've had patients who come in and take them every other day. Well, I was just trying to make them work. So every other day I took my medicine. And the problem is, these are chronic disease states. It's not about taking your medicine for 1 month. It's not about taking them for 2. It's about taking them for an extensive period of time to lower these risks. And people don't understand that. So I have my personal opinion about Medicare. I think it was definitely, I think it was an ambitious effort. I think it has done good for some people, but I think it's caused a lot of confusion. We have a lot of issues. My brother works for Humana, and there are a lot of agents who essentially, they try to advise people on the best plan to use for Medicare Part D, and a lot of people got confused and they opted out of their employer program. And once you opt out, you can't opt back in. So you have a lot of elderly people, and as you get older, your ability to process information isn't as fast. So you have people who don't understand why their medications aren't covered. Why are they now spending $4,000 or a certain amount of money before they can get coverage again? So it's a huge issue. The School of Pharmacy right now has a grant where they're trying to work to address some of those issues and close some of those gaps. Thank you. Thank you.